Welcome to the Executive Innovation Show podcast, where we bring you real executive conversations with industry game changers and thought leaders. We ask the questions you're thinking, what you're scared to ask, and we make your brain hurt afterward. With your host, Carrie Chitsey, co-founder and CEO of One Touch Video Chat, live video interviews, and the nonprofit Humans Helping Humans.
Hello, everybody, and welcome to the Executive Innovation Show. We have a great show for you today. We're going to be talking about telehealth efficiencies, pre and post surgery, brought to you by One Touch Telehealth. We have three amazing guests with us today. We are going to be talking to two now, and then we'll be talking to one later in the show. First, we have with us Dr. Sonya M. Sloan, better known as #OrthoDoc. She's established herself as a force to be reckoned with in a male-dominated field of orthopedic surgery. She travels around the country to extend her unique approach to patient care, including locum tenens and telemedicine as one of the first ventures of its kind. Her work in medicine has positioned her as a highly sought-after speaker in health awareness, health development programs, and motivational speaking. She also is the author of the book, The Rules of Medicine, a Medical Professional's Guide to Success. Dr. Sloan, welcome to the show.
Thank you for having me. I appreciate it so much.
Great. And then we also have Andy Poole, who's the CEO of Monticello Community Surgery Center. He's a multi-specialty ambulatory surgery center located in Charlottesville, Virginia. He has an innovative model that allows him to access and serve patients all across the country. He's a seasoned healthcare executive with a rich background in healthcare administration. And then later in this show, we're going to have Dr. John Noble Jr. He's the president and chairman of Better Day Health, a lifelong entrepreneur, and has practiced orthopedic surgery for over 24 years. He continues to have a very active practice and help Better Day comprehensive clinical operating system, and he's interested in technology and improving the efficiencies of practice of medicine. Welcome to the show, everyone. Thanks for joining us today.
Thank you.
Yeah, thanks so much for having me.
Well, great. I want to talk first, and Dr. Sloan, this is really for you. It seems like we get a lot of questions all the time of really how the role of the surgeon has really changed a lot, and especially over the last few years, with the physician and patient experience and that relationship with surgeons kind of driving all over the place, going from location to location, technology, and kind of going from fee-for-service to value-based care. Where have you really seen the industry change over the last few years from your perspective?
Technology. I mean, just the fact that we're having this podcast just lets you know where innovation is going and where our patients are also starting to go, young and old, specifically the millennial crowd, but definitely even the older generation, because they don't want to go into the mega centers, healthcare centers, even like in Houston. So technology has made the advance in medicine. I think we maybe is still a touch behind.
Yep. So
right now, telehealth is definitely at the forefront of that. Technology, apps, medical equipment that people can attach to, certain devices and that kind of thing. So yeah, by all means, technology. And if you're not in it, you've got to catch up.
Yeah, no, that's good advice. And Andy, from your side, being on the CEO side of a surgery center, you guys are doing some innovative things, kind of giving more pricing choice for patients, giving them more options than, as Dr. Sloan said, going to the big hospitals for surgery, being more transparent. Where have you seen that and how that model's changed for your surgery center over the last few years?
Yeah, as Dr. Sloan was talking, it made me think of a little bit. It's kind of funny that we're innovating by going back in time, where we're going back to a free market approach. But that's exactly what we're trying to do. We're bringing in the ability for people to make decisions about their healthcare by seeing a transparent price up front, including quality metrics and things like that on our website. So they're getting a value-based decision, which is something that's been absent from healthcare in a long time. And so as people do this, they're going to need more information. And telehealth is a great way to engage with the practitioner over a distance so that you can make those decisions, form those relationships in advance of seeking care.
Yeah, absolutely. And I think, we're talking about transparent price. We're talking about not only the patient experience, but the physician experience as well. And we have, you know, a lot of patients now that, you know, even the older ones that your Gen Zs or your millennials are the caregivers, and they're getting way more involved with the healthcare than we've seen in the past of, you know, it used to be with our parents, you didn't question what the doctor said, you just did it, right? And now you've got all these caregivers that are saying, do you really need this back surgery? And, you know, what are the pros and cons? And really kind of questioning and challenging, is this the right approach? Are there alternatives? Which leads it to the next discussion of, you know, those pre-consultations. A lot of folks are driving sometimes 2-3 hours to go see a surgeon that they feel is like the best in their field, or they've heard about for friends or family, or even Google searching, right? A lot of, and Dr. Sloan, I know you're huge on social media, so someone might have found you in Houston and, you know, be driving from Austin, right? But patients, we still want as a whole to kind of, before you make that drive, have that kind of pre-consultation and talk to that surgeon about, you know, is it a fit, right? Tell me, you know, what's my recovery time? Tell me the pros, the cons, things like that. And Dr. Sloan, you've used telehealth and been one of kind of the innovators on that pre-consultation, whether it's with the patient or the caregiver. Tell me a little bit about what you're kind of seeing in that, what kind of, you know, questions, decisioning. I mean, is it a competitive advantage for surgeons to have that face-to-face prior to walking in the, you know, in the OR? Tell me a little bit about kind of how you've been using that and what you're seeing from that perspective.
I believe this is where telehealth is going to make a huge difference, specifically in surgical scenarios, because you also need a second opinion. I tell patients every day, no surgery is a small surgery. And so, right, you know, you may have an older patient specifically with me and joint replacements, or like you said, something big like a spine or whatever, but no surgery is small. So you always want to have a second opinion. I think this is where telehealth will come in tremendously, specifically in surgical fields. Most of the times, probably 8 times out of 10, it's usually the parent and the son or daughter that want to get involved. And so usually those are the ones that are calling. They may not have all the specific details. They may not have the x-rays, but it's more of like, what does this entail? What are we expecting post-op? You know, what is the long-term 7-day, 14-day, 1 to 3 months? So they just want to know the ins and outs, basically. Right. And so those are probably most of the calls I get. I get social media inboxes. So therefore I have to have the disclaimer on all social media platforms that this is not my medical platform. This is, my personal, but I do it in a professional level. But you may see me being mom as well. So therefore, the inbox about a 3-level decompression infusion on your spine, I'm not going to answer questions about on social media. But I kid you not, daily, if not 1 to 2 on Facebook or Instagram, even the inbox on Twitter, less so Twitter, but always. So therefore, the need is there. People want to know. And sometimes I get things that are not even orthopedic related. So therefore, people will go by a brand or a image on social media that is becoming more and more important as well, because a lot of doctors aren't on social media. But for telehealth, like with our Rodocs, it is still very, very important for patients to be able to feel like that they can get other information, not be intimidated, I think is huge.
That is
because
big.
So many times you will go into a doctor's office and it is okay, well, you've got, arthritis. We're going to do a surgery. We have an opening next Wednesday. Here's the paperwork, sign the consent. We'll see you next Wednesday.
Right.
Well, most patients are different, characters. I have from culturally, you may need to pray with your minister, or they have to have family support, or they have to get their, things in order. And so you just can't, do that right off the bat. And so that's one of the times, most of the times, if they're questioning or they're not comfortable with the doctors, another time they will get a second opinion. But I tell patients, all patients, don't just take my word, get a second opinion always, so you're comfortable with it.
And I think as a follow-up to that, you're obviously in a male-dominated field and thriving as a, female surgeon. You've done a great job on kind of getting yourself out there from social media and so forth. And you brought up one thing that I tell physicians all the time is you've got to break down that wall of intimidation, right? Like you said, they see you on social media. You may be with the kids, you may be at church, you may be talking about something, physician related, but it takes down that wall. It's like, oh, well, she's a mom too. Oh, well, she's, yes, she's medically trained. She's amazing, but she's just the human too. And I hear a lot from surgeons that it really breaks down that wall on telehealth on have that, because we're sitting here chatting, you're sitting there, you don't have the white coat on, but I'm sure on some telehealth you do, but it's, hey, we're human to human, right? Mm-hmm. Yes, you're the physician, but now if I come into and do a surgery with you next week, I already feel like I know you. That anxiety, which is huge on surgery, right, is now already down. You already had this face to face. I may be home, I may be at work, you may be at your office, you may be in a hospital. Now we have that kind of rapport that also brings that patient anxiety down, which is big.
Yeah, and just the accessibility, for even the patient and the patient family, it's the fact that they can get to you without having to go through the hierarchy of powers that be and red tape. So that's a huge thing of, if I need not just the second consult or the post-op care, can I get to you?
Right. And then Andy, from your perspective, you guys are doing a lot with really the self-employed, the self-insured, and making surgery not only, more affordable than going into a big hospital for companies that are self-insured, but you have folks that are driving, I'm sure, pretty good distance from where you guys are. How do you see that on the pre-consult playing, and even having kind of that higher level of service for some of those employers to have those consultations prior to them coming or making that drive and going back and forth?
Yeah, it's a really good point. It's really an interesting part right now and where we're at in our business dynamic. So we are working with more and more self-funded companies, and it's interesting because you've got the individual who's been to their local physician, they've received a diagnosis, they've received the recommendation for surgery, and then their benefit structure, they want to create an incentive that creates better value. So they want to steer them towards centers like ourselves that offer a bundled rate that are going to be, multiples of 10 times less expensive than a hospital in many occasions. And so to do that, though, you've still got to have that personal element to it. You've got somebody who's at a stressful point in their life. They're looking at a surgery, as Dr. Sloan said, no small surgery. So how do you establish that level of trust to say, I'm going to fly? I know my local doctor told me to go to the guy down the street, but I'm going to fly to Virginia from Florida, which has happened just recently. It happens quite frequently. Stay in a hotel with a caregiver, of course. Go see this physician, meet him on Wednesday, have the procedure done on Thursday, and fly back on Saturday. How's this all going to work? And so, we do have a lot of different surgeons participating in this, and I will say not everybody participates with telehealth. Some of them, we do the more traditional model of getting the paper records and a phone call consult and everything, because we also want to be respectful of physicians' time and make sure that it's a good candidate that's coming to see them and we have all the information lined up. Telehealth does ease that tremendously, as well as really kind of get that critical establishment of a relationship before you walk into the office the first time, and ease a lot of that anxiety that comes with just with this model.
Yeah. And so, now we've talked about kind of the pre-surgery, now the patients had the surgery. As Dr. Sloan said, there's no small surgery. Having being the caregiver for my dad, I can attest that, even the ones that are going to be, day surgeries, whatever, when you've got somebody that's got chronic care conditions, everything goes wrong, right? Mm-hmm. You never plan for all the things that are going wrong. I want to go through some scenarios of post-surgery now, where telehealth, it's not a one-size-fits-all. It's not going to fit for every scenario, but where things are kind of working. One of the things we get a lot on the show from the surgeon standpoint is, hey, I can't really grow my business because I have all these post-surgery consultations, right? And surgeons typically do surgeries on certain days, because the other days they're seeing all the people that they did the surgeries, and it's filling up kind of the waiting room from that perspective. And so when we typically look at telehealth from an efficiency standpoint, if you're able to, go room to room, even though you may only be spending 7 minutes in a room or 5 minutes in a room, there's still the shuffling between, there's the wait time. And so that time actually goes up from an inefficiency standpoint, where telehealth typically those post-surgery follow-ups are 5 minutes, right? Maybe 7 minutes on the high end. But when you look at just the patient side for a second of, you've taken off work to go to kind of these appointments prior to the surgery. Now you've had the surgery, you had to take that work off, right? And now you have, depending upon the surgery, a 7-day follow-up, a 14-day follow-up, maybe a 20 or 21 or 30-day follow-up. You have all these and you're missing all these work. And the employer side and Dr. Sloan from the practice side, it starts to, in this convenient world that we live in, it starts to be a lot, right? And especially, I mean, Dr. Sloan, you can relate in Houston traffic, like me in Austin traffic. Going to a doctor's appointment, I mean, it's a 3-hour minimum gig with traffic, with parking, with, you know, God forbid you have an appointment in the morning or post 2:30. I mean, that could turn into an all-day event with traffic. But what are some, you know, what should, and Dr. Sloan, I'll go to you first. What are some of the post-surgical consults that physicians should be thinking about that can be done telehealth? What are the good ones to do? Because it can't be every appointment, right? Maybe that first one you can see a wound, although cameras in 4K now are so great. You know, you can see wounds, you can see incision, you can see acceleration. But what are your advice to other surgeons? What should you be looking at in that flow to say, these are the appointment types that could be done telehealth surgery? These are the ones that, hey, you got to come in, we got to do labs, or we have to physically be able to touch you.
Yeah, so the easy one is, number one, you want to make sure the patient's comfortable with a post-op visit via telehealth. A lot of times, actually, to be honest, they are not. They actually want to come in and see you post-op. That is a very intimate time. You know, this is someone that you've cut on now.
That
and they
first
actually
appointment,
want that special time. If you line it up and set it up right, where they understand that this is a convenient thing, and all I'm doing is looking at an incision. So incision post-op care is the ideal. A knee scope that doesn't really need to be fully evaluated with a hands-on, but I can see the incision, you know, they can unwrap it. It's not red, it's not hot, it's not swollen. They can bend the knee. I can watch them bend the knee and that kind of thing. And/or a physical therapist is there, you know, because they have a post-op rehab type of thing going on. That's ideal. Now, if they need a cast, you know, all bets are off. They've got to come in for a post-op cast or whatever else. That's a different thing. Or if staples need to be removed or whatever at a 14-day period. Then you want to make sure that, you know, initially, if they say at 48 to 72 hours, you want to post-op the patient just to check the incision, ideal. If they're going to have to come in 7 to 10 days later to get staples out and or a cast change or whatever, then, you know, all bets are off. But most times, 9 times out of 10, you really and truly can do a post-op visit with this patient that will give them the reassurance that everything went well. You can explain to them, because most times they don't recall exactly what happened. They're still in that post-op fog of anesthesia, or even with a block and everything that is going on during that day, they don't remember what you say post-op. So this is a time to reassure them, to talk to them, to ask them questions, to let them ask questions, for the family to ask questions that really does not need an office visit with overhead, from brick and mortar to nurse staff that you're going to have to take care of and all that kind of stuff. This is something that can be done from home, from the comforts of their home. Not a long drive, not a parking garage, not gas, all of that. So yeah, it's a huge convenience in the right scenario.
And what about and I'll take this question to kind of both of you, is, everyone is, the value-based care system right now, very concerned about, your patient going into the emergency room and penalties and surgery centers and hospitals and things like that. Now with telehealth, we have a lot of, specialty practices that literally with the click of a button for after hours, weekends, or, if, you do start seeing discoloration or you start having, change of condition, you can, with the click of a button, video with, whether it's a nurse, a physician, anyone from that perspective, say, hey, do I really need, show me what's going on? Do I really need to go into the emergency room and really trying to, take down those kind of change of condition calls that historically you just get phoned after hours or you get pulled out and you can't really kind of see what's going on. And then the token statement is always like, well, you probably should go to the emergency room, right? So where do we see that headed, as, hospitals are being penalized for 30-day readmissions, and it's kind of trickling down. Andy, from your perspective as, kind of the CEO on the administration side, where do you see that? I mean, does that give you angst of where kind of value-based care is going on penalties and things like that, or as kind of an outpatient, doesn't this apply to you guys as much, or where do you see that from that perspective?
Well, it's still, we still have quality metrics we track on things related to admissions along those lines. So even if the penalty is not there, it's still something, you want to do everything you can to make sure it doesn't happen and take care of the patient before an issue arises. And to Dr. Sloan's point, I think telehealth can be a component of that as well. And even further, out past the initial recovery phases, I think it can be used very well to stem off problems as they're arising later down the line. An example that comes to mind, I was thinking about it as you were talking earlier, was with some of the orthopedic surgeons that are involved here, using it with conjunction with physical therapy. If somebody's experiencing unusual symptoms that are kind of changing during recovery, everybody can be in the same room together. Even if they're not in the same room together, they can do it in an efficient way. So not just there, but home care. You're seeing more on home monitoring after larger procedures. So the more that can be done to catch a problem before it really builds, that's where technology can be beneficial, and that's where I think the industry is going to go. And that's a good thing. That's healthcare versus more of illness and sickness care. So you want to try to, even if it's involved in a big procedure like a surgery, it's still, how do you make sure there's nothing rising up that can be addressed quickly, easily, and resolved before it becomes something larger?
And I think, and Dr. Sloan, I'd love to hear your thoughts on this. I was on a call yesterday, and we're seeing more and more, as we look at the aging boomer population and more people want to age at home, not only do they want to age at home, but, there's a huge, obviously, rise in assisted living, senior living, long-term care, all different kind of criterias. But when you have somebody that's in assisted living or a long-term care facility or even new senior living where there's not as much nursing on staff, we're going to see more and more surgeries out of that. And the transport, you start to get into significant costs. And now you have maybe a nurse there or an RN that is now that caregiver. It's kind of a new category, as I like to call you have the customer and then you have the patient, right? And now you have to kind of service both, because you may be having a nurse from a long-term care facility say, hey, we're taking care of Ms. Smith post-op, but this is what we're seeing. And now you're having to video with the nurse in the facility, because if they have to then transport them back to the office or back to the ER, it starts to get really expensive from a transportation and logistics standpoint. So, as I think, anybody that's kind of listening, you have to not only just think about the patient communication, you now have a caregiver, and caregiver could be family, it could be a home health agency, be it the nurse at the long-term care, the assisted living. So Dr. Sloan, do you think of like this full picture kind of moving forward and how that's going to change your communication?
So going back to what Andy was talking about, the first part of the question, realistically, what I see in the near future, if we're not already there, is the fact that telehealth is going to be utilized as a triage system.
Yep.
We are going to see most insurance company providers will not allow you to get to, unless you're talking, bonus sticking out, massive heart attack, or, whatever. We're talking the non-really emergent, urgent kind of things that can be seen through a telehealth almost as a triage to say who you should go to, how quickly it should be done, which doc you can or cannot see, and in a timely fashion. That is part of the overhead as well, because I can tell you that I've had patients come in with no, proper triage, and I'm not sure how they get to us, with no x-rays, with no whatever. And now the shoulder doesn't hurt at all. And so they just come in to smile at you. So It was, a wasted visit for both parties, but at the same time, insurances are going to try to cut that out. The second part of that is when my initial encounter with telehealth was through TDC the Texas Department of Justice system here, inmates in UTMB in Galveston when I was training in medical school.
Yep.
And that was the first telehealth where we actually had the doctors on the screen actually looking at them, and we'd have to put the camera in. So yeah, you had other people from the inmates that were also in the room, because it wasn't a one-on-one,
Yep.
to the guard that was taking care of them, to the residents and the doctors that were in the room. So, okay, maybe you don't have your privacy because you're an inmate. However, same scenario now move forward to it's a nursing home, or it's a, physical therapy, as Andy was talking about, a therapist that now is on that caregiver's part, that those are going to have to be waivers or signed documents or whatever prior to, maybe that gives up that HIPAA that, that you're basically part of the caregiving team that's also part of that telehealth. And so that's definitely a component that we're going to have to look into, but it's going to be necessary.
Yeah, no, that's great. So before we close the show, we always close the show with what's keeping you up at night. And we always take out spouses, kids, all the things that really keep us up at night. So Andy, going to you first, what's one thing kind of that has you staying up at night in regards to healthcare?
I just, that's a good question. I didn't know that's how you ended the show. I would have thought through this a little bit more, but it's got to be the continued consolidation of healthcare. It's one of those things I know that some people are saying we're starting to see a reversal of that trend, but locally, at least, we're not. And so, the more independent providers that go away and become part of a bigger system, then the more expensive the healthcare system is going to be. And personally, I don't see it getting the efficiencies that are claimed around having everybody under the same employer. I don't see that necessarily happening. I see other opportunities like what we're talking about today to actually create those efficiencies by physicians and providers who have more independence and control and the ability to engage the patients more directly without those extra layers. So that's what's bugging me in the healthcare side.
Good. Dr. Sloan?
Okay, I have two. So one, of course, is the doctor burnout, the whole thing of us having lifestyle, and that's really be conscientious about taking care of ourselves and picking the lifestyle we want, which leads into the second half of, access for patients, as well as how doctors are going to take care of them in the near future. That's one of the reasons why I think telehealth is important. Everything from credentialing from state to state or whatever, it drives me crazy that there's different state licenses. That I practice the same medicine if I'm in Texas, Oklahoma, Louisiana, Kansas, Virginia, wherever I have a license, with locums or with telehealth as well. Medicine doesn't change because I cross a boundary. It is the same worldwide. I do a knee replacement exactly the same. I take care of cellulitis exactly the same, a cut or whatever else. So the bureaucracy that limits doctors to take care of more patients, I think that telehealth may be that boundary that can help, translate some of that, but that drives me crazy and keeps me up at night.
Yeah, it is a big thing. And I know there's companies now that with telehealth that do much kind of quicker multi-state licensing for bordering states. But I think that is, to your point, I think that is going to be a big, barrier, especially in these rural communities and shortage areas. I mean, you're not getting a bunch of, orthopedic surgeons to move to rural Iowa. So you're always going to, the shortage is going to exist. Telehealth can really help those areas, but without, getting, kind of cross state and bordering states, it's going to continue to kind of be an issue from that standpoint. Well, it has been so great to have you guys both on the show. Thank you so much. Such great insights. We're going to move to talk to Dr. Noble, but thank you both, Dr. Sloan and Andy, for being on the show today.
Thank you.
Thank you.
Dr. Noble, welcome to the show.
Hey, well, thank you, Carrie.
Well, great. We were having a great conversation before you came on, and I was talking to Dr. Sloan about really how has the role of a surgeon really changed over the last few years with, patient experience, physician experience, with all this technology kind of coming into play. So really wanted your perspective as well. Where have you seen kind of the role over the last few years really change, and kind of in what ways?
So I think that's dependent upon what type of physician we're talking about, and whether it's an entrepreneurial type surgeon or whether it's somebody who currently is employed and is still kind of stuck back 20 years ago. And what's shocking to me is how healthcare has really lagged our other industries in terms of technology. So part of my role has been to do everything I can to make the business of medicine better and to make our offices much more efficient.
Right.
And so we just absolutely love what is happening, and we think that there's just tremendous potential for those of us who want to embrace this new technology.
No, that's great. And do you think we talked a lot about really the physician experience and kind of burnout and running from, facility to facility and seeing patients in office and kind of that whole mix. Do you see the technology as, kind of your role? And I know you're very innovative. Do you see that helping with, having you not chart till 10 o'clock or see your family more? Or how do you see that helping with the physician experience side?
Well, that's what we've been doing with our company, Better Day Health. We've been working on trying to automate the process of everything in the office from the moment the patient calls until the global period is over, the 120 days of that global period as a surgeon, but also compressing the amount of documentation we have to do, because one of our philosophies is that we should never repeat anything. Once that information is available, we should present that information electronically and never have to duplicate processes. And that's one of the things that is so frustrating. For instance, if one were to go to an emergency department 20 years ago, you might have to write a patient's name 4 or 5 times.
Right.
We just don't have to do that anymore because of technology and because of everything we're doing, particularly with structured data. So, and then this whole other episode with telehealth and all the video tools that we have now, that's going to just open up a whole new game for us.
Yeah, that's great. And we talked about earlier, and I want to ask you kind of the same questions is, as we look at, you're in Louisiana, I'm sure, like Dr. Sloan, you have patients that, may drive an hour and a half, 2 hours, even more to come see you. And when you look at the path of, surgery of kind of the pre-consultation, maybe you even have to come in the day before, and then the, aftercare side of things. Looking at the pre-consultation for surgery, we have a lot now with your baby boomers. You now have caregivers that are asking you questions and wanting to know pros, cons, recovery time, all this kind of stuff. And what I call you have the patient and then you have the consumer, right? And Dr. Sloan talked a lot about how she's doing more and more telehealth on the pre-consult side of, meeting folks before they come in. And she even referenced to it being more kind of triage now where, hey, you don't even come in and have that until we've kind of had this discussion. Where do you see telehealth's role in the pre-surgery in your kind of arena, or, where do you see the best benefits or pros and cons from that perspective?
So I have kind of a niche practice. I do some things that are unusual that a lot of people don't do. So I do get a lot of these patients who come in from 3 or 4 hours away. And so they oftentimes don't know how to initiate it. And we certainly don't want them driving for 8 hours both ways and then come up empty-handed. We want to make sure that it's going to be a high yield if they come in. So nowadays we can get them to send their clinical information. We can get them to send their radiographs. I mean, they can send a disc. Hopefully at some point we'll just be exchanging this electronically from group to group. But for now, we're still having to mail CDs. But we can look at those before they come in. We can look at their x-rays, look at their MRIs, and then have a conversation with the patient and decide, is this something we really need to explore more? And we don't always have to do a physical examination. Now, obviously, if we initiate treatment, we'll need a physical examination at some point. But at least initially, to start the conversation, to make this more convenient for the consumer, I think it's just a fabulous way to do that. And that's what we're going to be working more towards.
Right. No, that makes a lot of sense. And then as we have the aging boomers at home where folks want to stay at home longer or more, we haven't even seen the rise of kind of senior living, assisted living, long-term care, things like that. Where do you see the opportunity now to be able to do that now in facility without the big cost of transporting somebody to your office or that back and forth? Is that an area that you've historically played in, or does that give you opportunity to play in that area? Where does that fit in the mix for you?
So in our circumstance, what we're doing is we're building all those facilities on campus so that we really can have our mid-level providers round on those patients. But in the more remote campuses, then we will probably have some type of telehealth presence. So instead of somebody driving 50 miles, particularly in a post-operative case, we can now, it just takes a smartphone to actually video the incision site, and we can do a quick post-op visit. And as you probably know, most of these visits that we come in the first 7 to 14 days, they just really want reassurance. They have normal bruising, normal swelling, and all of these things look normal to us because we see this all the time, but for them it looks horrible. And we can reassure them and say, oh, Ms. Smith, that's just a normal post-operative course. The bruising that you have, the swelling that you have is typical. Some people have more, some people have less. And then, if they call us in 4 weeks, well, that's normal post-operative inflammation. The warmth that you feel and all those sorts of things are normal. So that reassurance really helps us. And it particularly helps from a liability perspective, because the more reassured the patient is, the less likely they're going to get upset with us.
Yeah, and we talked a lot about that. I was talking about it. We're even starting to do a lot of work in the hospice space, and it's kind of similar post-surgery as well. As you have this changing condition, right? And as you said, I'm anxious because I'm taking care of my father, and I'm looking at something and I see this weird bruising, and I don't know, is that normal? Is it not normal? And all of a sudden it's after hours, and now I end up in the emergency department, right? Because not that anything's like crazy going wrong, but it's that changing condition that gives both the patient and the caregiver kind of that anxiety of the only thing to do is to go to the emergency room because it's 10 at night or it's 7 at night or things like that. And so, those kind of taking those front level calls from a telehealth perspective, then that would enable you to see something to say, yes, you do need to go to the emergency room, or, hey, just come in tomorrow, it's normal, or you don't need to come in, right?
Right. And the key word you said was anxiety. And if we can resolve people's anxiety, that can make everybody's experience much more pleasant, including ours, because the one thing we don't want is we don't want people to have anxiety for 3 or 4 days, come in, and then, this has become escalated. And of course, we know all the physiologic things that happen to people when they are anxious, but it's really the caregivers that we tend to have the biggest problem with. And so the other thing is this enormous overuse of the emergency department. So we need to do everything we can as specialists to prevent the inadvertent visit to the emergency department. It's wasteful, it's expensive, and quite frankly, things are ordered that should never be ordered.
Yeah.
And so when you have a normal post-operative wound and in 7 days the emergency physician orders an ESR, an erythrocyte sedimentation rate, of course it's going to be elevated. We just operated on them 7 days ago. So there are lots of tests that are routinely ordered in those circumstances that are absolutely not necessary. But if they had more clinical experience, they would know that. And just that simple telehealth visit for 3 or 4 minutes can reassure them and prevent a whole lot of trouble for everybody.
Yeah. And I think too, I think that's totally a great point. And I think too, as you typically look at the, surgery schedules, you're performing them on certain days. And then the rest of the time you're either doing new patient consults or you're doing post surgical consults, and that, freeing up some of that time. Obviously surgeons, there's only so many surgeries you can do in a week and burn out and all that kind of stuff, but you're freeing up a lot of that time. We had a physician on a former podcast say, hey, my telehealth visits are down to, 4 to 6 minutes because, we don't have to do a lot of the chatter of the room to room. And it's, hey, you're busy, I'm busy, let's see it, let's do this, and kind of move on. And still have that good kind of, bedside manner from that perspective. But I think we live in this busy world, physicians busy, patients busy, caregivers busy. How do we still have that face-to-face, which is still critical? So I do want to ask you, you've got your hands in a bunch of different kind of technology and so forth. Where do you see 2020 and 2021 from your perspective? What are kind of the big technologies that you think really are going to help you and help the health center there in Louisiana from a technology perspective? I know you've got some cool stuff going on.
So, we've really been focused on interoperability because we felt like 10 years ago, those were really the weak points in healthcare IT, and it really, quite frankly, still is. And so we're working on developing a system that from the moment the patient contacts us until we're finished with that patient, their billing and all the revenue cycle and everything else goes with it is in one system. So it's going to be a game changer for us. All of our revenue cycle, practice management, all the clinical documentation perspectives, telehealth, patient engagement apps, all that included in one central system. So we don't have multiple logons. We don't have all the conflicts that we currently have with trying to piece together programs. And it's going to be way more efficient for our staff. And so we can either communicate with the entire office via our platform. We can do chat. We can do secure messaging. We can send out our CCDAs, et cetera. We literally have about 60 programs already integrated together. We're on our way to probably 70. And it's going to allow this automation so that when somebody comes in and has a certain diagnosis and we propose a certain procedure, basically we're clicking two buttons. We're clicking the appropriate ICD-10 and the CPT that goes along with it. And that 120 days of workflow, which includes the preoperative assessment and the orders and all those sorts of things, as well as all the post-operative documentation will need to be happening. That's all teed up with a click of one button. So that's what we're working on. We're working on that automation, and we're using structured data to do that. So we think that particularly 2021 is going to be just a fantastic year. And we're no longer going to be behind financial industries and the airline industry for our IT systems, because I think we're catching up.
That's awesome. And when can we look forward to seeing that? Is that in 2020 or?
Well, actuality, we have 98% of the coding already done. We're right now testing our revenue cycle integration and our practice management integration. We've been using the clinical documentation for about 4 years now. So awesome. Just getting this final piece together, and then I'm currently vetting various PACS systems and various patient engagement apps and telehealth, for instance, to be integrated with our system. So we're really excited about the final product.
That's awesome. Well, we'll look forward to that. Well, the last question we always ask on the show is, what is one thing healthcare-wise that's kind of keeping you up at night?
I think it's the uncertainty of the future of reimbursement. It's the uncertainty of the fiscal solvency of the United States and what's going to happen and how does that affect healthcare providers and really healthcare systems. I think that's the biggest question. And the other real burning issue that we have is, our insurance companies are making it way more difficult to deliver healthcare. Yeah. And so that's really what I have heartburn about every day.
Well, awesome. To follow Dr. Noble, Dr. Sloan, or Andy Poole, click on the links in the show notes. As always, if you have any questions for our guests today, feel free to submit those and we will get you the answers. Dr. Noble, it has been such a pleasure to have you on the show today, and thank you so much.
Thanks, Carrie. Great talking to you.
Awesome. Thanks.
This podcast has come to a close. To hear more from the Executive Innovation Show podcast, subscribe, submit questions, and share the love. Follow us on social. We're everywhere.